I'm Dr. Angela Bates. I work at the Stollery Children's Hospital in Edmonton, and I take care of the pediatric pulmonary hypertension program there. I'm the medical lead, as well as I do pediatric cardiac ICU. So I see both inpatient and outpatient kiddos, basically all across Western Canada. So I think pulmonary hypertension in kids, the thing that sets it apart from other lung diseases is we talk about being subclinical, meaning a lot of these kids can live with this disease without having many symptoms. And by the time that they actually show up, they can be very sick. They can be as sick as being in the ICU. They can show up even as sick as dying from this disease. We have this window of opportunity to make a huge difference with all available drugs that we have nowadays, including oral medications, which we didn't have 10 or 15 years ago. And I think the other thing that's really remarkable is this is an amazing group of children that really, they'll still do a lot despite being quite sick if you look at their echoes and you look at some of their other different investigations. And so I think that's kind of remarkable about these kids. Again, also can kind of trick us as practitioners in terms of how aggressive we are with treatment. So I think sometimes we're not thinking about screening them, we're not thinking about doing an ECG or echo. They give us very few clues early on. Also, a lot of our gold standard tests are invasive. So the gold standard would be doing a cardiac catheterization, which requires sedation, a general anesthetic. It requires actually putting catheters into the groin. So those are all things that sound scary to parents, scary to kids, and we respect the fact that some of these kiddos, they have a high risk of something going bad during these procedures. So I think that makes it a bit difficult. That being said, we've really come a long way in terms of non-invasive investigations. Our echo technology is better. We now have cardiac MRI, and every day people in the radiology world are looking at trying to find more reliable non-invasive tools. For us, the challenge is a few things. So one, our group of pediatric pulmonary hypertension is very diverse. So two big groups are very different. You have these arterial pulmonary hypertension kiddos. They can either be hereditary or idiopathic or related to heart disease or other things like connective tissue. And then you have another group of developmental lung diseases. And so even treatments, are there certain treatments that are useful in one group versus another? Some of these kiddos are very little. So looking at non-invasive techniques of diagnosing and following these kids is very challenging. So that's really where a lot of our research is headed nowadays. And then just even clinical endpoints, because it's hard to identify what matters the most for these kids, right? Obviously, yes, survival matters, but is there something that we can follow as a marker that's a little bit more sensitive, that we can follow that will change earlier on in disease progression, that will help us to modify therapy? And then again, the other thing that's a little bit challenging is just even different drugs that are available. So oral medications, we do have a lot more. A lot of them aren't approved in pediatrics, so we certainly use lots of medications off-label, but even just what's available for them to be able to get at home, whether it's subcutaneously delivered or IV and so forth. That's what some of the challenges, but also the exciting areas are for us to move forward in PH. If you look back at the older literature, diagnosing kids late in the game, their prognosis was quite terrible. Median survival without treatment was around 18 months. Now that we know that introducing different therapies earlier on, these kiddos can live 10, 15 years, which gives them that window, one, to obviously be kids and do well, but two, to get to a point where maybe lung transplant is a better option than it was when they were 5 years of age. It also gives us more time to find better treatments. So certainly implementing therapies earlier on not only improves their survival, but just their quality of life, which really is what's most important to parents, to kids, and as well to us as healthcare professionals. In terms of advice for a general practitioner or a pediatrician in the community following these kiddos is that even though it's a scary disease, educating yourself is very important, empowering the families, listening to the families, and then always not being afraid to ask advice. We're never too busy to talk on the phone. We're never too busy to help follow these kids in the community with you, to see them in our clinic, to provide more education. And the biggest thing for these kiddos is quality of life. So although we sometimes may have to sort of negotiate what sort of therapies are best in these kids, really in the end, these kiddos should be at home with their families, out doing activities that they enjoy. And we work within those constraints, but to really focus on how can kids best live out their childhood. If you have a kiddo that just doesn't fit the normal mold of what you're used to seeing for common childhood illnesses like asthma, that sort of thing, that think about pulmonary hypertension. So if it doesn't fit and your tests don't make sense, certainly think of pulmonary hypertension. And I think the other thing is that you can do simple cardiac exam. Anything, if you can feel a second heart sound, that's abnormal. If the kiddo looks like there's a right heart failure, there's a reason for that. And a simple thing like an ECG is a great place to start. So there's a lot of things you can do in the office to screen these kiddos and then pick up the phone. The field of pulmonary hypertension, both in the pediatric and adult world, is always moving forward. And we really try to empower our families to really help facilitate that, because that is what the face of pulmonary hypertension is, and that's what it's all about. So I think moving forward, some of the focus we really want to do is looking at identifying kiddos and family members earlier on, and using things like what we have, these biorepositories, and trying to identify what makes certain patients different than others, and then really trying to tailor therapy to get the best outcome for these kids. So I think there's going to be a lot of excitement moving forward, and the biggest thing will be this should improve the care for our kids. My name's Angela Bates, and I'm aware that I am rare.